Bismillah. Assalamu alaikum, everybody. This is Hamza Alzghoul. I'm one of the internal medicine residents at the University of Central Florida, North Florida Internal Medicine Residency Program located in Gainesville, Florida. And today I'm going to be starting a crash course for internal medicine common topics that you encounter either in the emergency department, in the ICU, or even in the outpatient clinic. My goal is to cover the most cases internal medicine residents or even internists or fellows, especially in the major IM fellowships, the major topics that all these people encounter um, on daily basis or even on weekly basis. So the topic I'm going to start with is exacerbations of lung diseases. So first I'm going to be starting with asthma exacerbation, and then I'm going to move to COPD exacerbation, and after that we'll briefly talk about bronchiectasis exacerbation. It's uncommon, but a lot of people kind of ignore it when it presents. And then we try to cover other chronic lung diseases exacerbations like interstitial lung disease, specifically IPF, idiopathic pulmonary fibrosis, which is also more specifically called usual interstitial pneumonitis, subtype of ILD exacerbation. So to start with, we're going to be starting simple, first with asthma exacerbation, and then we'll move to the other topics. So, starting with asthma exacerbation. As we all know, asthma is an inflammatory condition. And based on that fact, that is very well known currently, we tend to deal with it, treat it as such. So, the GINA guidelines that control kind of asthma um, treatment in the United States um, very recently incorporated inhaled corticosteroids, specifically low dose inhaled corticosteroids, in the management of the earliest asthma and the stepwise therapy. So, even at step one in mild non persistent asthma, we start with inhaled corticosteroids, that is a low dose, as compared to previously when we usually um, started with a short acting beta agonist as needed for these patients. But now we kick it at the beginning with a low dose ICS, usually along with a short acting beta agonist that we are going to call SABA from now on. So, um, moving into an exacerbation of asthma, what could exacerbate asthma? So, the most common cause of asthma exacerbation is a viral etiology, and that is as opposed to COPD, which is which is more likely to be exacerbated by a bacteria. Even though viruses remain the most common cause of COPD exacerbations, but as compared to asthma, COPD exacerbations tend to be more likely exacerbated by a bacteria. That's why in a subset of patients with COPD exacerbations, we tend to give antibiotics, but in patients with asthma exacerbations, antibiotics are not among the treatment modalities. Other causes include environmental triggers. In some patients, it can be triggered by PE, for example, a pulmonary embolus, and one of the common triggers is smoking tobacco, either first-hand or second-hand smoking. So moving into how does acute asthma exacerbation present? Usually, an acute exacerbation of asthma presents as acute onset shortness of breath that is associated with wheezing usually and a cough. And one thing you have to watch out for in these patients is usually they report that they use their risk inhaler at least 3 times and they did not experience a sustained improvement in symptoms. And the way I'd like to triage or even look at asthma exacerbation is by looking at the peak expiratory flow. So usually, when I see an asthma exacerbation patient in the hospital, I ask them if they ever measure their peak expiratory flow at home, and they have a baseline. And if not, I can um, estimate their baseline based on their race, height, etc., etc., and compare it to a peak expiratory flow that I measure in the hospital. And a peak expiratory flow can be really helpful in triaging these patients that are kind of in the yellow zone. So sometimes you have a patient who calls you while you're in the clinic and tells you, hey doc, I have used my short acting beta agonist 3 times for now, and I still have shortness of breath. What should I do? So the way I go by it is, if the patient has a peak expiratory flow meter at home, I advise them to measure the PEF. And if he tells me, for example, the PEF measurement is less than 80% after 3 treatments with an inhaled SABA, then I tell them, go ahead and start oral corticosteroids, systemic corticosteroids. Just send them to the pharmacy to take it. But you have to know when to tell the patient to come to the emergency department. So if the patient tells me that his PEF is um, from 70 to 80 and he does not really sound short breath, I would probably take some sort of a history over phone and advise them to come to the emergency department if they worsen, and I'll just send them systemic corticosteroids to take as outpatient. However, if the patient tells me, for example, hey doc, the PEF that I measured is less than 50%. So the first thing I tell these patients is just rush to the emergency department as soon as possible, because the PEF measurement tells me that something really bad is might happen if these patients don't come to the emergency department and get treated with short-acting beta agonists and systemic corticosteroids, whether oral or IV. So that is number one, how to use PEF in triaging patients and when to add oral corticosteroids or systemic corticosteroids in general, because a lot of these patients are really not able to take PO. Some of them are vomiting, some of them are in very acute dyspnea to the limit that they cannot swallow. So you just go ahead and give them IV steroids instead. Um, So when the patient needs to come to the emergency department, what do you do? So the way I go by it is I just look at the patient, and one rule we are gonna follow here throughout our entire lecture series is, if you see a patient breathing, then something really bad is going on. And what I mean by this is, if you look at your friend or whatever who's in front of you, or if you look even in the mirror, you should not see yourself breathing, because you're breathing using you're breathing usually passively. You're not actively breathing, meaning you're not using accessory muscles of respiration. If you are actively breathing, putting a lot of energy in breathing and using accessory muscles of breathing, then you are in a tough spot. And in the scenario of acute asthma exacerbation, somebody needs to act very fast, because if not, you might need to be intubated. So the general rule of thumb we're going to follow here is, if you see somebody breathing, meaning if you see somebody using his accessory muscles of respiration, then that guy is in trouble. So that is from looking at the patient. Number two is, if you see somebody with an asthma exacerbation wheezing on auscultation, you gotta be careful here. So if there's only expiratory wheezing, then this patient is in less severe status than somebody who has inspiratory and expiratory wheezing. If you see somebody with an asthma exacerbation who's not wheezing at all, then this guy has a silent chest, and this is not good. This is actually bad because they're not moving enough air to hear that wheeze from bronchoconstriction. So physical examination is key. Usually, patients with silent chest, the first thing you do is a stat ABG, and you look at the CO2 of these patients. CO2 is normocapnic or hypercapnic, then they might need to be they will need to be intubated because they are going into respiratory failure and respiratory fatigue. So the key in asthma is just look at the patient, and then if you see the patient stable enough, does not need intubation at this moment, then you complete your investigations, which include, of course, usually we do an arterial blood gas if you think it's needed. Usually these patients in earlier stages, they are um, they are usually um, hyper let's say they are usually hyperventilating because they are in distress. So usually the p arterial O2 is normal to slightly elevated, and the pCO2 is decreased. They have hypocapnia because their minute ventilation is increased by either increased by usually increased respiratory rate, and sometimes they initially take more tidal volumes than their baseline. If you start seeing these patients going into normocarbia and then hypercarbia, then they are in deep trouble and you have to act fast. Okay, so that is the second thing you can make use of, the ABG. Um, One other thing you can look at the ABG that can give you a clue is an elevated AA gradient, and that is an elevated alveolar arterial O2 gradient. And what that basically means is it's a parameter that is representing the difference between the pressure of oxygen in the alveoli minus the pressure of oxygen in the arteries. So usually these two things meet unless there is some problem at the alveolar capillary membrane barrier. And in any scenario of dyspnea, you're gonna be having an elevated A gradient, except in two cases. Number one is hypoventilation. Number two is high altitude. So in these two cases, AA gradient is gonna be normal. Other cases of hypoxia in general, AA gradient is gonna be high. Okay. Um, we are gonna talk about AA gradient when we discuss arterial blood gases, so let's not delve too deep into that. Then I will usually get after, of course, getting a history and a proper physical examination, I will see a chest X-ray. Usually, chest X-rays are devoid of infiltrates in the case of asthma exacerbation, unless there's a concomitant, for example, pneumonia. And for the sake of asthma exacerbation specifically, you usually don't see anything significant on chest X-ray. Sometimes you can see it hyperinflated if the patient is auto-peeping, for example. But usually in patients with asthma exacerbation, you're not going to find impressive findings on the chest X-ray. So that is regarding chest X-rays. Then I'll obtain a PEF. So I tend to look into at PEF values. Um, and I tend to group it into three groups. Group one is above 80. These patients are fine. If you give them SABA and PEF goes above 80, then I'll just discharge them home on oral corticosteroids if the first three treatments of SABA did not achieve a PEF above 80. Okay, and if it is 70 to 80, then this is a mild asthma exacerbation. Same thing, I'll discharge them on oral corticosteroids. If PEF is 50 to 69, then this is a moderate asthma exacerbation, and I would definitely admit these patients. And some people also say 40 instead of 50. And if it is below 40, I would admit these patients to the ICU. These patients need ICU level of care, and they need back-to-back continuous nebulizers and need to be taken very seriously. So mainstay of treatment is SABA, and you watch for response, which is usually albuterol. So something we call jumbo nibs is just back-to-back high dose albuterol. The usual dose of albuterol we give is 2.5 milligram. For these patients, we give in severe or moderate asthma exacerbation, we give 5 milligrams of albuterol back to back, or we give even 10 milligrams of albuterol back to back. But one thing you gotta be careful in these patients is sometimes really high doses like 10 milligrams make them very jittery, very shaky, very distressed even. So I usually avoid the 10 milligram, and I usually use the 5 milligram if I need to use a jumbo nib and a high dose of nebulizers. Something you can add is also a short-acting muscarinic antagonist, just like ipratropium. So ipratropium is a short-acting muscarinic antagonist. And one thing that comes as a combined SABA and SAMA is something we call DUNIBs. You will find them if you're in practice. You probably are very familiar with this, which is a combination of a SABA and a SAMA, usually ipratropium and albuterol. So you can just let the respiratory therapist know that this patient is, for example, in a severe exacerbation and needs DUNIBs back to back. Of course, not all patients need DUNIBs back to back. Some of them can benefit of some of them can benefit of Q4 hour or Q6 hour of nebulizers if they are not in a severe status. And then the systemic corticosteroids is extremely important in the treatment of an asthma exacerbation. So you usually give these patients either IV corticosteroids or oral corticosteroids if they are able to tolerate oral steroids. And what I usually give is Sulimedrol 40 BID or 40 Q8 hours, depending on the patient, if they need IV treatment. So that is in terms of the treatment of an asthma exacerbation initially. Then we're gonna briefly talk about intubation and the asthma patient. So in some resources, you're gonna find very specific, kind of indications for mechanical ventilation and intubation in patients with an asthma exacerbation. But personally, and that is just kind of style issue, I try to avoid looking at these specific I try to avoid memorizing these specific guidelines, but it helps if you want to be kind of guideline directed. However, my feel or my My way of doing things is just look at the patient and know the information in these guidelines. Just keep it in the back of your head and look at the patient, and you will come up with a decision. So it's not really hard to take the decision on when to intubate in asthma patients. And some people, when they some people say, when you're in doubt, try non-invasive positive pressure ventilation, and if it fails, go for invasive mechanical ventilation, unless of course there is contraindications um, for for non-invasive positive pressure ventilation, like the patient is vomiting or the patient is not really awake and alert, and the glass coma scale is less than 8, then these are contraindications for non-invasive positive pressure ventilation. You go ahead directly with mechanical ventilation. In patients with asthma, if you see that the PCO2, as mentioned earlier, is normal or climbing up, let's say climbing up to normal and then becoming hypercapnic, the patient is becoming hypercapnic on the ABGs, then I would usually go ahead and intubate. And also, if the patient was initially very wheezy and suddenly became silent without improving, you're not seeing the patient improving, but he's just having a silent chest now, then just go ahead and intubate. Something I like to look at in these patients is also something we call abdominal paradoxus or diaphragmatic paradoxus, which is, let me explain that to you. So usually when you inhale, when you take a breath, a deeper breath, your chest goes out and your abdomen goes out. So it's chest out, belly out. And when you exhale, your chest goes in and your belly goes in. So it's belly in, chest in. So they usually go together. In patients with severe, really severe respiratory distress, what happens is you're trying very hard to use your accessory muscles of respiration uh, to the limit that your diaphragm gets fatigued. So when you try to use your accessory muscles of respiration to expand your chest, the diaphragm is not moving anywhere, so it stays where it is. And the accessory muscles of respiration generate so much negative intrathoracic pressure to push the diaphragm up. It like sucks the diaphragm up, and your abdomen gets sucked with the diaphragm inside while your chest is expanding. This is called diaphragmatic paradoxus, diaphragm paradoxus, or paradoxical breathing. And that usually, when I see that, I have in the back of my head that an a clue in the back of my head that this patient, either now or very well soon, will need to be intubated. Okay. Another tip I would like to give you guys is if you are having a patient with an asthma exacerbation who is in pain for whatever reason, just avoid morphine. Please, just avoid morphine. Morphine may cause histamine release because it can cause non-IgE dependent mast cell activation, which causes the release of histamine, and that will eventually lead to bronchoprovocation. As you know, histamine is one of the um, mediators that are used in bronchoprovocation tests, just like the methacholine challenge test. You can either use cold air methacholine or histamine to diagnose patients with asthma and a normal PFT. Um, then, after the patient is intubated, let's say you intubated these patients and you sedated them. These patients, when they're intubated and sedated, they get much more comfortable because they are in really bad distress. And mentioning distress, let me mention that other point, which is distress. So, a lot of people know that short acting beta agonists are not very selective. They can also activate beta 1 receptors, and when you activate beta 1 receptors, you lead to tachycardia. And patients with asthma exacerbation usually present with tachycardia due to the hypoxia and the distress they have. So they are already tachycardic. And what happens is usually the nurse comes to me, or sometimes the respiratory therapist comes to me and say, "Hey doc, the patient is on albuterol nebulizers and um, he has tachycardia. Would you like to try ipratropium instead?" So when this scenario comes, I say, um, so SAMAs can also cause tachycardia. I know not to the limit of beta 2 agonists. Beta 2 agonists can cause more tachycardia than SAMAs, short acting muscarinic antagonists, but they can cause tachycardia as well. That is point number one. Point number two is, you know something, if you give a patient with a heart rate of 120 and a really bad asthma exacerbation, albuterol, what do you think is going to happen to the heart rate? Is going to be higher or lower? Um, a lot of these patients, from what I saw, once you give them SABA, they they get generally better, and even the heart rate goes down because they are less distressed, less hypoxic. So initially the heart rate might climb up to the 130s. Don't freak out as long as they are vital stable. Once they get enough bronchodilation to get enough air in and out, then they will start feeling calmer, and they will their heart rate even will go down. So don't be freaked out if you see the heart rate in the 110s, 118, 120. Don't freak out and just give the nebulizers the albuterol or even the ipratropium or both. Okay, that is one tip I want to share with you guys. Coming to mechanical ventilation and intubation. So before you intubate these patients, you are going to bag them, right? And one tip I'd like to give to any patient who is in a COPD exacerbation or an asthma exacerbation, any obstructed patient, when you bag an obstructed patient, don't bag too quickly, because if you bag too quickly, these patients require a prolonged expiratory period. So if you bag them too quickly, you're not giving them the time to expirate. And what that will lead to is that they are gonna have a progressive air trapping, just like a breath stacking. The breath is stacking inside their lungs. You're not giving them the time to exhale the air that is accumulating inside their lungs. So this air trapping will lead to a positive end expiratory pressure that is accumulating, because more volume is more pressure, you know? And what I mean by volume here, not the volume of the chamber, I mean the volume of air that is going inside. So more air within the limited lung volumes is more pressure. And that will lead to buildup of pressure and lead to what we call an auto PEEP. The lung is accumulating more and more pressure, and it's like a vicious cycle. So in patients with an asthma exacerbation, I let's say my focus is to maintain an O2 saturation of at least 90%. Don't worry about the PCO2. PCO2 can wait. Don't worry about the PCO2. My goal is not to wash out the PCO2. And in these patients, I usually follow an approach called permissive hypercapnia, where I permit CO2 to be high a little bit. And my target PCO2 is 60 to 70 or even 80. 80 is fine, I don't care. And a serum pH of 7.2 to 7.5 is okay in patients with an asthma exacerbation. Just don't worry about the PCO2. Just permit them to be slightly hypercapnic up to 60s to 70s or even 80s or even 80 with a pH of 7.2 to 7.25, but correct the hypoxemia with a target SAT of 90%, which is equivalent to around P arterial O2 of 60. Got it? So that is in terms of ventilating these patients. So just listen with your stethoscope and check that the ventilation is not kicking in while the patient is still exhaling. The ventilator, sorry, is not kicking in while the patient is still exhaling. That way, you have to adjust the respiratory rate to allow the patient more time on the ventilator. I mean, to allow the patient more time to exhale what is inside his lung. And some ventilators are very useful. So like the ventilator in our unit, you can do you can um, hold at end expiration during an expiratory hold maneuver. You just let the patient exhalate and you hold the vent and you measure the pressure that is left inside the lungs at end expiration, called expiratory hold test. And if there is intrinsic positive end expiratory pressure, it's gonna show in the ventilator. That way you can decrease the inspiratory to expiratory time. You're gonna decrease that ratio, meaning that you are allowing more time for exhalation, and that will lead to the alleviation of that auto PEEP. So when you put an asthmatic patient on a ventilator, use low respiratory rate, use small tidal volumes, and high inspiratory flows and high inspiratory flows. What I mean by inspiratory flow here is you give a faster flow of oxygen during inspiration over a shorter duration of time. That way, your time of inspiration is short, but the volume you are getting in during that time is high, and then you allow more time for exhalation to get that volume out, allowing for maximal air exchange while allowing for adequate exhalation, avoiding the buildup of autopeep. Okay. So the point of high flow on inspiration is the allowance of more time devoted to expiration. So that is the conclusion of our acute asthma exacerbation lecture, and I'll see you later in our lecture on COPD exacerbation. That is going to be next. Last thing I would like to mention is just that there is no rule of antibiotics in asthma exacerbation, unless of course there is concomitant lung infection, like concomitant consolidation that looks like a lobar pneumonia. Then you're going to be treating that infection with antibiotics. Thank you very much, and please share the video and like the channel and subscribe to it. This is my first lecture of the I Am Alzghoul crash course series. So just follow us and stay tuned for the next lectures. Thank you very much. Bye.